Great. So, I know everybody is tired. It's to be expected. We're now going to sort of have the last session of the conference, and it is all about reaching new heights together. And in this session, we're going to start off with a patient partner, and then there's going to be 3 clinician talks, and then there'll be the opportunity to do Q&A. When everyone's walked in, I have been given one task before I bring up Fred to talk, is that for anyone from Canada, there is a request that you hang around at the end for a photo. Okay, so Andy, I can see you. Okay, just squeezed in. Okay, Audra's told me that we have to get a picture for PSC Partners Canada. Okay, so we're going to start, and we're going to ask Fred Sabernek is going to come up and give a patient perspective on patients in the research process. I think most people know that Fred's been a long-time ally and supporter of PSC Partners, and has PSC, and is a great advocate for the disease and for PSC Partners seeking a cure. So Fred, do you want to come and tell us a bit about your perspectives?
Okay, how about now? Ooh. Okay, so the conference and patient perspective on PSC. So actually, the one thing I can tell you is that when I first came here this year, I felt like crap. And it was a result of a medical event that I had last week, and I'm still trying to sort of recover from all that. But I feel a hell of a lot better today and yesterday because I'm with everyone here, and that is just so encouraging to me. There's a lot of newcomers here, and I know I've had a chance to meet some of you. Hopefully I'll meet more of you. Welcome to the PSC family. We've got some great researchers that you've heard from today. I am so impressed with the presentations that we saw this morning. Just a little perspective, when I first came to a conference in 2009, one of the big topics was whether or not URSO worked or didn't work. And that was like the only thing they talked about from the research side. And the conclusion was we didn't know. So hopefully everyone's heard what's been presented here this week and is really encouraged by where research is going. From the very quick, I know I'm almost out of time here, but from the very quick perspective of my own, I've been in 2 clinical trials, you know, clinical trials are really important. Research is hope. We really need to participate if we can. I know there's a lot of barriers sometimes, but please think and consider about participating in a clinical trial if you're able to. It's a very personal decision, and you'll have to make that for yourselves. So I think that's really all I'm going to say here right now. So thank you very much.
You can stay up if you want. Okay, so hopefully my microphone's working. I'll need this to give to Professor Tandon. So we're going to now move on to, as I said, 3 clinician talks. And the first talk is Professor Punita Tandon, who's one of my colleagues from Edmonton in Canada. And she is a world expert in the management of chronic liver disease, cirrhosis, but more to the point about living with chronic liver disease. And what Punita's going to talk really about is health and wellness, and some of the amazing work that she's done around health and wellness and how that can benefit people living with PSC. Thank you, Punita. Do you want to, let's try this one.
Okay, I can't. Oh, I can, and now it's working. Okay, excellent. Thank you so much for the opportunity to be here, and thanks, Gideon, for the introduction. I just want to tell you how inspiring you are as a group. You've made me cry this weekend. and you've really inspired me to continue to do the research that we're doing. So thank you so much for allowing me to be here. So I wear two hats. I'm a transplant liver specialist, and I'm also an integrative health researcher. And I get to talk to you about empowering health and wellness in PSC. No relevant disclosures. So let's just say it out loud. Living with PSC, it's hard. And it's hard on your body, it's hard on your mind, it's hard on families. And not only do you carry the weight of PSC, but also other stressors such as work and home and major life events and other trauma that happens. And all of that gets processed through, our brains. And depending upon the level of threat that we perceive those events to be, that results in a response of acute stress. And that stress response can look like outside behavioral changes, but it can also cause changes inside. And that's the physiologic responses that happen. So for an acute stress response, that's increases in your stress hormones, increases in epinephrine, increases in other cytokines that are associated with inflammation. And over time, if there's multiple of those acute stress responses, then that can cause chronic stress, which causes wear and tear on the body and on the brain. And that can be quite draining to someone's battery. And this concept of a battery, I think, is really important, and I'll bring it up during the rest of the talk. So in medicine, we think of the battery as your physiologic reserve. And you can think of this like your safety zone or your buffer. And we know it's important because if you start with a higher battery when you have an acute health event or a life event that happens, then you're going to go down a little bit in your energy. It's going to drain that a bit, but you're going to bounce back up. So it's really, really important that we learn strategies to recharge our batteries. So you're wondering, okay, what can I do? And I think you've learned a ton actually over this beautiful conference so far. There's been such incredible lectures that have been given. And I want to just stress that you are not alone. All the health professionals in this room, pharma, PSC partners, we're dedicated to two things. We're dedicated to finding a cure, and we're dedicated to helping you live well with PSC now. So with that, I'm really excited about this idea of an integrative approach to hepatology and PSC care, and Dr. Lai spoke about this on the first day, where we're not only just managing illness, so getting you to obviously do your things that you need to do with MRIs and blood work and other tests and giving you medication for your symptoms, but we're also filling that tank and we're empowering your health and wellness. Okay, so that together I think is the most powerful strategy that we can offer as physicians. So I have put this into what I hope will be easy to remember as the ABCDEs. And alongside your medical care, these are the most evidence-based strategies that you can use to fill that battery. And as we're going through each of them, I want you to kind of think about for yourself, and everybody will be different, where's your battery at for each of these potential strategies? Okay, A, I'm not going to make you do sit-to-stands. Gideon asked me that already, so I said no. But activity and exercise, if you could bottle a pill and have a magic pill, this would be it, okay? It has such tremendous benefits, not only centrally as far as causing your heart to be stronger, your lungs to be stronger, your blood vessels to dilate, but it's also got all these other peripheral benefits on organs like your brain. So the brain fog that Dr. Swain was talking about, exercise improves cognitive status and cognition. It reduces depression. It improves your bone strength. It improves your muscle, builds mitochondrial volume, and it improves your liver health. This is a study I really like to show. It was one of the older studies that we did back in 2014. We had 19 adults with cirrhosis, a couple of patients with PSC as well in there. And what we asked them to do is come into our facility and bike with us for 8 weeks, 3 times a week. Now, if you look at these people at baseline, look at their passport or their biological age, they were 57 years old. We got them on the bike and looked at their physiologic age, they were 80 years old. So their bodies were older than their actual biologic age. 8 weeks of biking, 3 times a week, 30 minutes a day. Physiologically, they became 13 years younger. Okay, so their batteries supercharged in that time. And not surprisingly, they had less fatigue. So what does this mean, or could this mean for you? It really means as much as you can do. That's possible for you, and start slow is totally fine. We're looking at a target of 20 to 30 minutes of what we call resistance training. So that's either using your body weight, using hand weights, or using exercise bands, plus 150 minutes of aerobic exercise. How do you know you're doing enough? You know you're doing enough if you can talk, but you're short of breath. And anything goes as long as you're increasing your heart rate. Okay, the B is for breath work. This, I think, is a superpower technique. We're breathing all the time. We have 20,000 breaths a day that we're taking, and all of those are an opportunity to really shift your body state and your physiology. So breath work is like breath training. It's using your breath consciously in a controlled way to improve your physical and emotional health. And it's not just us that's doing this. This is world-class athletes that use breath work, CEOs, the Navy SEALs. Like, this is a power technique for many people. So it works by various techniques. A lot of vagal stimulation comes in here. If you're new to breath work, the 4 techniques that I would suggest that you could start with is, number 1, the easiest is a sigh, and doing that for 5 minutes. 5 minutes was all it took in one study to actually improve mental state. Belly breathing is another one, so just hands on your belly and feeling your belly expand. So we're not breathing into our chest, we're going down into our belly. Box breathing is the one that the Navy SEALs do. Look that one up, it's a good one. And then Dr. Lai went over 4-7-8 breathing, which is another really powerful one. And again, we don't need hours a day of this, we need 5 to 10 minutes a day with significant benefits. The C is for connection, and this is connection internally, and then I'll talk about externally. Dr. Kohut gave such a beautiful lecture today, and I think this comes down to the fact, again, that this is hard, okay? And there are heavy emotions that come with this, the sadness, the fear, the worry, and naming and working through some of those emotions is really important so they don't weigh us down. So whether that's with a counselor, whether that's journaling or other expressive ways, a beautiful gentleman in the audience doing some drawing, whether it's introspective practices like meditation, again, as little as 5 to 15 minutes a day, improvements in mental health. And also, Dr. Swain was talking about those objective markers. These techniques have shown improvements in inflammation in the blood and also in the brain MRIs, okay? So we can change these things with these practices. External connection, I don't even know if I need to talk to you guys about this because you have this down. Like, this is the most tightly knit group I have seen, and I just want you guys to give yourselves a hand because I think this is absolutely incredible what you guys have put together here and how you support each other. So if you're okay with that, give yourselves a hand, guys. And just know what you've built is powerful. So this is a study from 2010. It's an old one, but I really like it. I'm not expecting you to read it, but what it found, it looked at multiple studies that were looking, how can we reduce mortality and what practices do that? What came out number 1 was social relationships, higher than stopping smoking, higher than stopping drinking, higher even than exercise for actually lowering mortality. Okay, so definitely tap into this and keep that going. D is diet changes. We don't have a specific diet for PSC, but we sure do have a lot of evidence in the literature about what diets are good for healthy aging and also chronic disease management. And this, I think most of the evidence weighs towards the Mediterranean diet. So we're looking at reducing sweets, reducing red meat, increasing fruits and vegetables, lots of colors on your plate. And I think we'll learn a lot more about how this impacts the microbiome and it impacts gut health. The E is for education. And when you're living with a rare condition like PSC, I think you guys could tell me many stories. I've heard several this weekend already about going to medical professionals and maybe them not even knowing what PSC is. This is so important to get empowered with knowledge so you can advocate for yourself in situations. And so beautiful information on PSC partners seeking a cure. And then the last but not least is sleep. So this is our natural body's restoration. Adults generally need 7 to 9 hours of sleep a night, but the quality of sleep is as important as the quantity. These are my top tips from the literature. Number 1, try to get out and get some light during the day, so at least 30 minutes of bright light in the morning. Avoid screens. Try and get those blinds that block light if you can in your bedroom. Keep a cooler sleeping environment. Don't eat too late if you can avoid it. So finish your last big meal at least 2 to 3 hours before bed. If you have a lot of thoughts that come up that prevent you from sleeping, try journaling. And that's been super helpful for many of my patients. Limiting caffeine. So caffeine, we know is good for the liver, but maybe try stop by 2 o'clock. Or for some people even earlier so it doesn't interrupt your sleep. And perhaps the most important has been sticking to a regular sleep schedule. So going to bed and getting up at the same time has been actually in the literature one of the most powerful techniques. So maybe just take a moment and think about where did you on these ones, where would you have scored the highest? Where would you have scored the lowest? And what would be your entry point to starting to charge your battery a bit more? And certainly I wouldn't suggest taking on all of these at once, but even one baby steps at a time, 5-10 minutes a day, could be a really good start. Okay, for the just last few minutes of my presentation, I just want to share some of the research that we've been doing and how we've been taking those ABCDEs and trying to translate that knowledge into action. And in our lab, we do a lot of digital health research to make those actionable. So I'll just share with you a little bit about our latest trial, which is the Empower trial. And this is, it was a 12-week randomized control trial where we did an online chronic disease skills and mental health program, which involved many of these alphabets. It was developed alongside a big group of patient partners who we're very, very grateful to, and then a big group of medical experts. 825 patients were randomized in this, some including PSC as well. And what's unique about this is that it has both a psychology component to it, as well as all of those mind-body kind of practices, so movement, breathing, mindfulness, so combining those two skills together. And the results were powerful. So this is just the quantitative results I'll go into in a sec, but we also interviewed 100 patients and really got their feedback, and some of the stories were really incredible how it shifted their mindset. We saw significant improvements in depression and anxiety. We shifted fatigue by almost 20% reductions in fatigue. Demoralization improved by 26%, so that's feeling like you have life purpose, feeling like you can cope. And we shifted frailty. Frailty is really important, especially as you age, improving things like balance and strength. So that's a fairly significant improvement in that marker. Now, what are we up to now? We're really interested in actually taking interventions and doing home assessments beforehand to tailor those assessments. Tailor those programs. So everyone in the room would maybe get a slightly different version of the program based on what your home assessment was. Where are you on your sleep tracking? Where are you with your wearables, on your activity? How strong are you? So doing home-based assessments can really help us to do that. We're also very excited about the potential for this grant. This is not yet funded, but it's being led by Dr. Donna Avon, who's a health psychologist who I'm sure you've heard of. And this study, if funded, will look at Empower, a similar program, what I've shown you, to Empower amped up with psychologist support, and comparing what those two are like. My last slide on this, I'm so excited about this study. It is funded, and this is the wellness of the people that are beside us, that love us, that care for us in the good times and the bad times, our caregivers and our care partners. So we got CIHR funding to run the CAROL trial, which will launch early next year. We're looking actually for caregiver advisors on this, so if you're interested, we'd love to have you on our panel. And this will use an app to look at caregiver wellness. So my take-home message is, living with PSC is hard, and the stress can result in wear and tear. And if you take one thing away, I just want you to know that there is some stuff that you can control when it feels like you can't control anything. And I would encourage you to think about the ABCDEs and which one maybe you could work with. I hope that you'll join a Future Empower program, and I promise that with your help, we'll keep pushing forward and we'll bring more research and knowledge and support into this space. So thank you for your attention, everyone, and you're a wonderful group. Amazing.
Well, thank you, Punita. I think my speaker's working. That was, as ever, always inspiring. You always inspire me. And hopefully, I think it's just very good practical advice that can really change our patients' quality of life. We'll come back for questions at the end. We're now going to move back to the interface between the PSC and inflammatory bowel disease. Josh doesn't need introduction because he's been up here enough, but he's a professor of gastroenterology, world expert, Professor Koznick, on inflammatory bowel disease from Harvard Medical School, and he's going to talk again around PSC and IBD and the collaborations we need.
And do you have?
I do.
Yes. Oh, great. Thank you. So, thank you so much, and thank you all for hanging in there. Thank you again very much for that very nice recognition last night. And I also want to recognize not just my team and everybody who's been part of this, but also the Resnick family, who really recognized this need. Frank and Barbara's grandson has PSC, and so they approached me, and now this has been an ongoing effort. They've been remarkably generous, and both in terms of support, but also in terms of a vision of how they want this to develop and how they want to help this community. So I thank them. I also want to reiterate two things that both something that Fred said and Punita. One is what Fred said in terms of just the importance of being part of the research, where it's a partnership here, and so whether it's going out to the tables outside and seeing whether any of those trials may be of interest, and there's also a movement now to do trials where you don't necessarily need to be at a center. You can be at home. We have one where a nurse comes to your home, and there's others that we consent online and get blood or stool or other things from a distance. So just that's available. And reiterating also what Punita said is things that may seem relatively minor, like breathing or movement, can have such a profound effect both psychologically and physically that it's really important and can have a bigger impact than you would guess. So what I want to do today is just sort of be a bookend to what at the beginning of the conference we spoke about a lot of questions that we had, and what we had talked about in the day before the conference started here with a group of gastroenterologists and hepatologists. And what I wanted to do is just sort of talk a little bit more about not necessarily just IBD and PSC, but really where are we as a summary of research and what's the road ahead. So a little bit about past, present, and future, and really going through medically just very briefly. And I also want to say, I'm not going to go into very technical details, but I also want you all to realize that don't sort of be intimidated by some of the science. That certainly when I got into this, I was, and you realize that a lot of it's not quite as complex as it seems. And my hope is that ultimately we're going to find answers to some of these questions that are not overly complex and difficult for someone who's not in science or medicine to understand, but they're very straightforward with a very simple thing. And even though it's maybe not the best analogy, when we think about H. pylori, the bug that causes stomach ulcers, before that there were all sorts of wild theories of how all these different measurements of different things fit together. And it was very complicated, and then it came down to something that was much simpler. I don't think PSC is going to be as simple as a single bug. It's more complex than that, but I also don't think it's going to be overly complex. So I think we're hopefully going to be moving towards that. We started looking first at genetics, and in huge efforts, Norway group and other groups in England and in the United States try to decipher the genetics. PSC sometimes runs in families, so can we find something that is a causative or contributes significantly? There were numerous clues. One called UBASH3A came up as a very strong or stronger than some of the others, but it wasn't specific for PSC. It's often seen with several others, such as diabetes type 1. And so it was interesting, but overall the genetic contribution to the disease seems to be relatively small. So I'm not sure, this is, yeah. So it didn't give us a clear direction of where to go. It was interesting, it was a huge effort, but I wouldn't say that that is where I think the primary understandings are going to come from. Immunology has been very interesting and much more complicated, and particularly more recently there's been some identification of some potential cells that start in the GI tract and may migrate to the liver. And so that may be something that connects. It's not a common event, but it may be something that's very important, and is that provoking an inflammatory response? I think, though, that guided by the response of the therapies in inflammatory bowel disease, we've relied on the idea of, can we just knock something out? So medications like Remicade or Humira knocking out TNF, can we do that? Or can we find some other protein if we just use an antibody or some other molecule to knock it out? Are we going to help things? So that's worked in IBD, but it doesn't work in PSC. So why is that? There's clearly an immunologic component, but it may not be that it's purely an immunologic disease. There's something else that's kicking off this inflammatory process, and trying to understand that is really one of the issues. There's some interest, as was mentioned, there's a particular T cell subtype, a type of inflammatory cell called the T regulatory cell that acts to suppress other cells, and so that's one area where we're trying to look at and say, is this an area, can we use medications that can increase T regulatory cells, and it's more broadly immune suppressive in a very safe way, and might that be a way of going that? And there was a case presented of that, and we're sort of trying to look into that as something. And what's also very interesting in terms of as an inflammatory disease that was raised in our conference before is that even in those of you who don't have inflammatory bowel disease, when they've done studies where they take biopsies of the intestine or colon and do very detailed studies, not just studies where they're looking under the microscope and other inflammatory cells there, but looking at very subtle ways of seeing, are there other components of inflammation? It seems like it may not be significant, it may not be important, it may not need to be treated, but at least it gives us a clue that maybe this is a combined system where one component or the other or both are off in some way and provoke problems in each other. So it may be that there aren't really subtypes, but they all are unified in a certain way. And then there's some more recent evidence, some from Scandinavia, some from our own work, and others, that the mitochondria, the power sources of the cell, may be a target, may be one of the key issues. And that then starts the inflammatory process. And so that's interesting, it's early, but I think there's going to be more work done in that area and may be productive. The microbiome, the gut bacteria, the gut viruses, the fungi that are there are something that's very interesting. It's the enormous expansion of knowledge, and in medicine these days, everything is blamed on the microbiome. So sometimes we have to be a little cautious, but I think in inflammatory bowel disease and in PSC, we're making tremendous advances. I think it's really beginning to bear fruit in an important way. It's not just looking at who's there, but what are they doing? So there's been this very strong identification now of a dysbiosis. So what's different about the bacteria? What's different about the bacteria that cause disease in PSC and in IBD? And I think we're beginning to understand function and what not just who's there, but what are they doing? And I'll talk a little bit about one theory. One thing is that there's a reduction in something called a short-chain fatty acid, one that's butyrate, and why that's so important is it has important effects on the immune system, and it's the primary fuel source for the cells that line the colon. So not every cell in the body prefers glucose. Different cells prefer different types of things. The colon likes butyrate. Overall, we think we've reduced our butyrate levels for everybody, but then in someone with ulcerative colitis, it's even lower. And we've shown that it's also low in PSC, and that might have important impacts on immune function and in health otherwise. And there are other bacteria probably produce other molecules that increase the permeability that may be central to what happens in PSC as well. And then something that our group in particular is focused in on is there's an increased production of hydrogen sulfide by the microbiome. So what's hydrogen sulfide? Hydrogen sulfide is what makes rotten eggs stink. Some of you have been at previous conferences, heard about this a little bit before. And I'll just tell you a little bit about what we think might be going on. We've submitted this for publication. We looked at a large cohort, about 433 people, some with PSC, some healthy controls, some with Crohn's, some with ulcerative colitis. And what we've shown by looking not just at who's there, but we looked at all of the genes in the microbiome. So when we look at human genes, I don't know, there's maybe about 30,000 genes that we carry around as humans. The gut microbiome that you carry around probably has more like 2 million. So some of my colleagues who are collaborators here worked on this with us and really tried to decipher what's going on. And then we also looked at what's called the metabolome, or what's the products that these bacteria are putting out. And we showed that there's a huge amount of sulfur compounds that are produced. And it's not just that. So hydrogen sulfide in the body does all sorts of wonderful things. It's what is called a gasotransmitter. So it informs other cells what they might do. It helps heal. It does good things. But when it's in the gut, in the lumen, just free range, it can cause troubles. What does it do? One thing is it can block the uptake of that butyrate that I mentioned, so the cells get starved. Another thing that it can do at a higher level is it can poison the mitochondria. We don't know for sure that's what's going on, but we have some data to support that. And then what happens is some of that gets up into the liver through that portal vein that you've heard about, and it gets metabolized by it gets turned into other things. And some of that gets bound to bile acids. One in particular is called taurine, and the idea is, we're going to get rid of this. Your liver knows what to do with it. Your liver says, I'll take care of you. My job is to metabolize things. I'm going to get rid of these sulfur compounds. It sends it into the bile, sends it into the stool, and you're going to get rid of it. But the microbiome has another idea in PSC. It's going to send it back up to the liver. So you get this circulation of sulfur compounds that doesn't happen in people with ulcerative colitis. And so we think that may be part of the problem. And then some of you were probably part of a study we did. It was a very small study where we took people with PSC and we introduced them to the study, and we did this sort of throughout the United States. So it was one of these studies that you didn't have to be in Boston to do this, and we gave people dietary advice, and people were randomized either to something called the specific carbohydrate diet, which some of you may be familiar with, which is a higher protein diet, or a low protein diet, or basically a vegan diet. And we treated people people stayed on it for about 8 to 12 weeks, looking at what happened in the stool at 4 weeks and at 8 weeks. We were looking at sort of what we would call secondary endpoints, what happens to the bile, what happens to other things. And to our surprise, the alkaline phosphatase actually came down. It didn't come down dramatically. It was sort of about 80%, though, who were in that had some reduction. Some were just 10%, some were 40%. So we were amazed. We were delighted because it may validate this. Is this a small part of what happens in PSC? Is this a larger part? Is this accurate? So we're just gearing up to do another study where we're going to expand on this and do it more profoundly. I'm not advocating for this diet at this point because it's a little too early, and you need protein. So how to balance all that out is important, but at least gives a really important clue that we think is really exciting. And the microbiome includes also viruses and fungi. There are numerous clues. There was just a recent paper that was very interesting, suggesting that Epstein-Barr virus, which most of us have, 60 to 80% of us have this, but it may be that Epstein-Barr is an important risk factor. Some people are even suggesting that is it the primary cause? Is it a chronic infection? Now, Epstein-Barr may just be related to autoimmune diseases. It may cause autoimmune phenomenon. Multiple sclerosis is closely associated with EBV exposure or infection. It also may be also when you get EBV. So it seems to be protective at a younger age, but more of a risk at an older age. And whether this is a direct infection or whether it predisposes to autoimmunity, we don't know yet. We're looking into it further with the group that had that paper. So we're excited about this. and at least it's another pathway, it's a new pathway that hasn't been explored, and so we're very excited about that. And also looking at the fungi, what other things are there that may be really important as well. You've heard a lot about the role of bile. When we go to medical school, we think it's there to digest fats, but it does so much more. It has a role in immunology, in health of the colon, and promoting sort of restoration of the lining of the colon. It protects the mitochondria, and there's an important role in fibrosis. So that's such an important area, and that's getting much more attention and making real progress there. And then fibrosis, the scarring. What about the inflammation contributes to fibrosis? We heard in our scientific session before the really interesting ways that this may happen. And so what's important is not just can we halt fibrosis, but can we actually reverse fibrosis? And in the study of Nora Urso and others, some of those people actually had an improvement in their fibrosis, and some even had resolution. So it's tremendously exciting because we want not only to come up with a cure, but those of you who say who've had it, who then improve on some medication, hopefully that we'll have in the near future, we want to be able to reverse the damage that's going on. So looking into this area is sort of critically important. And then biomarkers is really important. So you've heard somewhat, we use alkaline phosphatase all the time, and we measure that frequently, but it's inadequate. So we want to find other ways of doing this so we can determine prognosis, determine response to therapy, potentially identify subgroups. You've heard about wind. Wind is one important way of trying to do that, to collect samples and then see what happens over time and find different biomarkers. We're engaged in a very exciting project that's similar. We call it Leviathan because it's turned into this sort of monster. It's a huge effort. We have lots of samples, and one set of samples that I'll just share with you that we're very excited about is from the Department of Defense. It's what happens is if you're in the military, you're required to give blood every 2 years. They're screening for various infections. And they keep a biorepository. So I believe it's in Colorado, where they have about 80 million samples. And what you can do is you can then go and say, well, we'd like to get samples from people who hadn't yet developed PSC, but we'd like to get their samples 2, 4, 6, 8 years before. So you're sort of going into a time machine and saying, what were the really early events? Are there biomarkers we can find before the disease was diagnosed to say these people are at risk? So it took us about 4.5 years and all sorts of agreements. Dealing with the government and with our own institution isn't easy. And 3 weeks ago, we received 1,600 samples. Now that's 400 samples from each of 100 in ulcerative colitis, Crohn's, PSC, and healthy controls. And so the group, many of whom are here, are now microaliquoting those into tiny little fragments, and we're going to look at that in a whole variety of ways. So we're tremendously excited as one opportunity, and many other people are working on this as well. So what lies ahead? I think there's tremendous amount of momentum. We're really excited by the conference that went on before, and of course this conference here. It really inspires us in a very profound way and keeps our eye on the prize, which is really developing a therapy that's going to be effective. There's this increased growth by the PSC partners, which is so wonderful and really a partner in making all of this work. And also industry is one part of that and moving that forward. There's also been growth in PSC in itself, not as part of autoimmune liver disease or part of a broader problem of cholestatic liver disease, but really seeing it as a field in itself, and that's been helpful. So where does this bring us? I think it brings us to a very exciting place. I think there are key areas of therapeutic focus. For immunology, can we find triggers? Microbiome, can we find additional things? Is EBV a culprit? Can vancomycin produce a long-term benefit by changing that? Can we manipulate the microbiome otherwise? And there's promising possibilities that you saw here. Can we treat PSC? So when we think about treating PSC, can we identify a therapy that's effective for PSC? Obviously, that's what we're all looking for. But can we also cure it? That's a strong word, and we're very hesitant to do that. But I think we can get closer and closer to what causes us to really think in terms of that. And perhaps even more importantly, can we prevent it? Can we prevent it by thinking about EBV? So is there, say, people are working on a vaccine. Can we find biomarkers of people with inflammatory bowel disease before they develop PSC? So can we really jump in early? And ultimately, that's really what we want to do, is it's not just finding a treatment. We want to find out how we can prevent it so it never happens. It doesn't even need therapy, and so we're working on that. When we think in terms of hepatitis C, 35 years ago, we didn't know it. We didn't know what hepatitis C was. It hadn't been identified yet. There was a poor prognosis. There was no cause known. We would just monitor it. We would follow liver tests, and we would hope for the best. Now there's a cure. There's an oral therapy, 8 to 12 weeks. It's well tolerated, and that's over. So I'm not suggesting that in PSC we need to wait 35 years. I think it's going to be much faster than that, and I think we're on a fast track right now. I think we all need to work with a sense of urgency, and that's sort of what we're doing, and the inspiration from this conference encourages us to do this. I genuinely think we're on a threshold to something that's going to make a huge difference in this disease. There's so many people working in so many different areas that hadn't been before, so many promising studies. So we're all partners in seeking a cure. And there's so many different ways we can each contribute. And when I think back on the first session here, and we heard about the remarkable story of Brooke and Michelle, and they were worrying about, should we give our best hope for Addison, our daughter, should we give this to Michelle? And the struggles they went through that, and remarkably inspiring. I think there's a bright future ahead. I think she made the right decision in a particular, because I really think Addison will not need a new liver. So thank you very much.
Okay. Thank you, Josh, and I echo your sentiments. So I have the privilege of, I think I can put this down actually. I have the privilege of closing the conference, at least in terms of slides. We'll have a chance for some Q&As before the end of the afternoon. And what I'm going to do is, just give you some of the closing thoughts. I knew that when I put these slides together last night, or maybe this morning, that most of you would have had seen too many slides by now, okay? And therefore I didn't have to make them data rich, okay? But this is around future work and, the outcomes that we're looking for, okay? And I think what you've heard throughout the conference is, and there are other places in the world with tall buildings other than Denver, so I thought I'd have a picture of the CN Tower, and it's the same thing. Why not climb to the top? Okay, we are going to be more aspirational, and that means that we'll be able to make a difference for PSC. And, it does nestle amongst these autoimmune diseases, and I echo some of what Josh said about the idea that maybe PSC should become a sort of a thing of its own. But in the world of liver disease, it nestles between two other autoimmune diseases. At the top of this little picture that we've got here, we've got the small bowel disease, PBC. We have got phenomenal treatments for PBC because of research, and our patients living with PBC are infrequently getting new livers, and their quality of life is improving. Autoimmune hepatitis is very steroid responsive, and our problem in autoimmune hepatitis is not the treatment, it's trying to get treatments that are better tolerated. But your disease is sitting in the middle, okay? And it's this constriction of your medium to small, your medium to large bile ducts that is the problem. It's concrete around your bile ducts, and that's causing biliary obstruction. And our standard of care, that's the problem. We have to tackle that, and we have to move forward. And we've already heard the differences over the 21 years worth of PSC Partners conferences and the optimism that there are drugs coming that are picking away at different things. Okay, so we're able, and I spend a lot of my time educating the GIs and the hepatologists, the internists about the management of PSC. And this is where we're at the moment, and we know that we will do better. Diagnosis by imaging, use of ERCP, surveillance for cancer, and we keep saying it, research, because we know that to get to the top of the CN Tower, we're going to have to do some research. Okay? And I'll go back to the slide that I had when I opened the meeting about making an impact and going across the 6 domains of how we can make an impact. So I gave some thought, and I'm just going to give you some different concepts about that impact. First and foremost, it's amazing to see that PSC Partners are at the front of making an impact. It's not just about bringing you together today, bringing investigators together, bringing industry together, but PSC Partners is the sponsor, the owner of the WIND PSC project. It's one of many projects that they're doing, but it's a line in the sand that the charity has moved to owning and leading research that will benefit you and other PSCers around the world. This isn't a study, it's a real-world comparator study which will be used, and the data will generate information for trials and for biomarkers. It's not easy. There's already over 250 patients recruited, and it's going to be support trial design, it's going to support biomarkers, it's going to support quality of life, it's going to validate quality of life measures. At the same time, we're all pushing for new science. And I just wanted to show you this picture. This is actually part of a grant that we put in, and it's similar to some of the work that you heard earlier today. The use of new science, and one of the new sciences that's very, very exciting is circulating DNA. So you can pick up fragments of DNA and changes in your DNA in your blood. So we're trying to raise the money to take this to the next step for PSC and in the context of PSC cholangiocarcinoma, where our patients will be giving us blood, okay, at different stages of their disease. Some may have cancer, the majority won't. We'll have all of their clinical information, including their imaging. We'll get their circulating DNA signatures, and then we'll put it together to see whether we've got another new biomarker to really improve our treatments. And yes, we're doing this with patient participation to try and understand how to design it, but equally we're very aware that if we tell you that you're having a biomarker study, there are implications to the result, okay? And we can't just give you the result and then walk away. We need to work with you to learn how to use that result. So, yes, thank you, Panita. We all need to find time to breathe. Okay, this is Lake Muskoka. For any of you who want to visit Canada, it's a great place to breathe, as long as you come at the right time of year when there aren't mosquitoes or black flies, okay? But that's clearly been a very important message for this conference. I think we can all take away, because when we breathe, we think better, we feel better, we'll have better ideas about how to cure PSC. So, number one, a prompt and clear diagnosis. What I hope for the future is we'll raise awareness of this disease, and I think that will help our patients. I hope we're better at communicating. I hope I'm a better doctor than I was when I qualified 30 years ago, okay? And that I communicate in a better way, and I'm still willing to learn, and I hope my peers will continue to work with us and communicate better, because that communication is key. It's not a diagnosis and walk away, okay? I hope we'll increase early diagnosis and we'll embrace artificial intelligence. I think that's where some of the efficiencies of AI are going to be amazing, and I hope that will drive discovery science, because we do need to discover the cause to make a difference. Okay? I hope we'll get to the world where, because you've all worked together as a community and you've each given something, and that means you've gained and given, okay, that we'll get to more personalized therapy for the individual that we see. And it's different at different times in your life. It's different managing a 16-year-old, managing a 25-year-old, managing a 75-year-old. Okay? It's different whether you've got inflammatory bowel disease or not. It's different whether you've got other autoimmune diseases. But that will allow us to so-called deep phenotype, personalized prognostics, so that instead of going to Dr. Google and being told the prognosis for PSC is this, you're going to get the information about what it means to you personally. Okay, and that may mean that the answer is there's 35 years of very, very good health. It may also mean that the answer is that you're on a trajectory to quicker for transplant, which is important information for you to plan and for your doctors to work with. It'll allow us to target cancer surveillance. We have a big problem in PSC. Cancer is devastating. Fortunately, it's rare. But applying surveillance to everybody is not actually logical, and that's the reason we aren't making progress. We actually need to target the cancer surveillance to the right people, and we need to have the biomarkers to help us. And then, yes, again, it comes down to all these amazing integrative physicians who seem to rule the world. It's got to be multimodal intervention. It's the liver, bowel, and it's the body. I should have maybe put brain, but we aren't going to succeed unless we are actually holistic in our approach. We want to prevent end-stage liver disease. We want to prevent cancer. we want to target normal. That should be our aspiration. Normal liver tests, no fibrosis, no cancer, and yes, as Josh said, no transplant. We'll keep using transplant until we have better things, because transplant is miraculous and changes people's lives. But we would prefer to be hepatologists who don't work in transplant centers, who actually prevent all of those things from ever happening. Okay? Symptoms are key, and we increasingly recognize that, and we recognize how you feel is going to impact on how you function, okay? And we recognize doctors are the worst people for appreciating the importance of symptoms. It's not always our fault, but the system doesn't help us. We need to measure symptoms better. It's not as easy as we think. We know that. We're getting better at it. We need to value symptoms better. Okay, of course we value length of life, but we need to value quality as well. And that means that we need to listen, but proactively treat, because we will have new treatments for symptoms which will change people's lives. And again, it comes back to mind and body synergy. Okay? In terms of inequity, I hope that at some point we're going to be in a better position to set standards. And we'll set those standards, and that will allow you to advocate more clearly for your quality of care. Okay, and that will be part of the engine that gets us closer to cure, because centers will want to meet those standards, and part of those standards will be discovery. And that will include signposting success. Where are the programs that are looking after PSC the best? How do you access them? How do we make sure all patients are seen in the right place and the right time? And that means empowering you as individuals. Not that PSC is your whole life. That is not our goal. But at the times that you're focusing on your PSC, you know that you're empowered to do it to the best of your abilities. And that will overcome some societal obstacles. We'll never overcome all of them. And yes, championing innovation and excellence. That's what the last 2 days has all been about. For us, it's been 3 days. Ask new questions. There really aren't any stupid questions, okay? And sometimes difficult questions, prompt difficult thinking, but new ideas. That will allow us to be brave and not Luddites and engage with science. And it's a bit scary to engage with some new science, and we have to learn, and not everything pans out, and engage with technology. And again, that's a give and take. But we'll all have to embrace change, and that includes the physicians who look after you, who may need to change their perspective on how and when to treat, and that will allow us to measure outcomes. And so with that, I can bring to the end of this talk, and we'll take some Q&A, but, I hope that you can leave here empowered, okay? And, I want to thank you all for being here and for being active participants in the last few days. And again, thank all the organizers for actually putting this all together. And we'll now have an opportunity to take some questions, and we'll try and answer them. So I think you can ask your questions, you can write them on your cards, or you can come up. While I'm waiting, if there are any questions, and by the way, people, if you're tired, we don't have to have a 30-minute Q&A. We're happy to have a Q&A that matches your all of our energy. But I wanted to ask Dr. Tandon, how do we recognize that what you're describing is important, okay? But how do we get value to that so people will pay for it? Because we've got to get our providers and insurance companies and governments to pay for what you're talking about. So do you have any sort of ideas about how we'll actually integrate it into the clinic rather than it being something that patients go and seek themselves outside of the clinic? Oh, sorry, there's another microphone. Try this one.
Yeah, I think that's key, and I think the answer is research, right? We have to actually show that these interventions do shift outcomes, and that hopefully longer-term interventions, longer than 12 weeks, start to shift cost benefit to the system. I think that's when they're gonna really start to pay for for interventions, and I do believe that they can. So things like exercise, nutrition, mental health, if we can do that, there's likely going to be less visits to the hospital. Potentially we see that in other conditions. So
How do you think you'll
future.
change do you think you'll change your clinic day? How do you think you'll try and change how you book your patients? Is there a way that you can actually see that actually changes? Or do you think that's even a harder pinnacle to climb?
Do we think that it's
Well, longer
yeah.
visits or different kinds of visits, or
If we're actually the ones that are doing this?
well, because you're going to be a provider, presumably. You're doing the course in Arizona. I'm assuming that
Yeah.
you actually want to embed it into your day-to-day
I think
life.
that's so cool. I mean, I think there's going to be, not every hepatologist is going to be an integrative hepatologist, but I do think that some of us, myself, Dr. Lai, for example, others who are interested are going to take this on as more of a strategy. Everyone should be informed in integrative health principles, and hopefully all hepatologists should say to their patients how important these strategies are for wellness and health. Because I know you guys really value, when you come to your docs and they give you advice, that you do take that seriously. So I think it's changing the minds of some hepatologists, to be honest, to say, listen, guys, this is actually really important, and it shifts outcomes.
I think what would be really cool is that, if we often see our patients once a year, twice a year. If we could sort of find ways like in advance to understand what the patient wants to discuss, and then, some visits could be more medical and some visits could be more mind. Okay. Now, whether we can actually do that, but I mean, that would be still using the same time that we've got in the real world to look after you, but adjusting the use of the time and being flexible, because sometimes it's more important to talk about one thing and sometimes it's more important to talk about other things.
Yeah, and that's why I'm so excited about the digital too, because it allows, that scalability.
Okay, so I have a question here for Josh. It's an inevitable question, Josh. The hydrogen sulfide story is interesting. Do you want to speculate a little bit about therapeutic implications? And what are you thinking about binding agents or bismuth? Do you think there's anything, where do you think that's going to head?
Yeah, so I think there's lots of interesting opportunities. So we are currently doing a trial, which you can find out more from our booth out there, and some of the team who's running that are here, called the Dolphin trial. So we're using a compound that's a variant of B12A called hydroxycobalamin. Hydroxycobalamin's been approved for cyanide toxicity, so it binds to cyanide, but it also binds to hydrogen sulfide. Now, it's not like just a simple pill. We had to manufacture these because we're using doses that are thousands of times higher than what you'd get from just a B12 supplement, because it's not taking advantage of what B12 does normally in the body, but it's taking advantage of what it can do by binding hydrogen sulfide. So that's one type of study that we're doing now. We've enrolled a number of patients, possibly some of you here, and we're looking at next generation and other things like that, and whether we have a study going on for both ulcerative colitis, but also PSC. So we're very excited as one way of saying, is that something we can do? Another one is then, can we reduce the sulfur intake, and can we alter that through diet? And so we did that pilot study I mentioned, and now we're looking at the next generation of that as well.
Yeah, I mean, I think it's fascinating, and there's obviously a whole world of nutrition as a therapy, and in fact there have been clinical trials of some nutritional management of IBD, which were quite successful in the UK, where they got some pretty good results for managing ulcerative colitis. And we already know that in Crohn's disease, historically our pediatric colleagues have used elemental diets and liquid-only diets to actually put people into remission. So clearly it's something that we need to try and do more of, although, as I think you're probably the expert on it, much harder, in fact, than giving someone a tablet is to do a diet. A dietary manipulation study is actually another league above me prescribing an injection. So just to stick with you, Josh, on that theme, what about fecal transplantation? Where do you think that's going to head? Do you think that's still something that needs more work, or do you think it's too blunt and it's not going to be the answer?
So when we did do a pilot study, Dr. Allegretti, myself, and some others at the Brigham did a small pilot study, 10 people with PSC. We saw some minor changes. The problem is it needs to be targeted, meaning we need to understand how we need to change the microbiome. So for those of you who know C. difficile, an infection that can sort of take over the colon, that is an area where fecal transplant has been enormously successful. You sort of throw some stool in there, and now they have it available as capsules, and it's approved by the FDA, and that can cure C. difficile, or at least put it at bay. We were hoping that for PSC we might get lucky. We had some minor changes, and I think what we're doing now is we're moving away from just let's take somebody's stool who's healthy and throw it in there and hope for the best, to saying let's have defined populations. Saying here, can we create a population of 10 or 20 bacteria that may be critical, but what do we need to have them do? How do we do that? There was one, I don't know what happened, that someone in Canada was developing it, which they called repopulate, but I'm not sure what happened with that one.
Probably didn't do so well. Oh, we might have heard it. I know, Panita, I'm going to obviously, as the real Canadian up on the stage, you have to take this question. Okay, does cannabis use affect symptoms and/or prognosis in PSC patients?
Yeah, that's a really good question, I must say. I don't know that we know. So what I tell my patients, and Gideon, you can fill in what you tell your patients, but essentially I'm open to individuals using cannabis if it is helpful for their symptoms, because I don't believe that we have really strong data showing that it's harmful. But again, it I think is a space that needs more research.
Yeah, I mean, I think it speaks to some of the things you heard from you and from Jen Lai. We've got to look after the whole patient, and the whole patient will want to have good exercise, good nutrition, and the whole patient may wish to use cannabis. We obviously don't want people to smoke, okay? But the whole patient may drink on occasion, and we just have to find ways to advise our patients holistically to be healthy. And what that ultimately comes down to, everything in moderation. Okay, it's obviously not good in excess, but it would be foolish of us to believe that to suggest that it's harmful. I don't think that evidence is there.
No, well, so there has been some work done in Crohn's disease, and it has a variety of things that might be anti-inflammatory, but also can be pro-inflammatory. But it has also other effects, obviously, on pain and even motility. So if someone's having some diarrhea, they're having abdominal pain, that can improve a little bit. So in a study, randomized controlled trial of cannabis in Crohn's, it showed a benefit by disease markers of well-being, but it didn't show any reduction in the inflammatory component. So people felt better, they didn't have as much pain, they had a little bit less diarrhea, but it didn't really change the disease the way other medications can.
Okay. The great thing of doing Q&A for PSC patients, there's so many questions. We did the Q&A session, I just did it before, and we managed to fill nearly the whole 45 minutes, and I didn't have to do any preparation because you brought so many questions to the floors. Fantastic. I'll keep with you for the second, Josh. There's a whole story and a whole literature about Crohn's disease and about Crohn's in sheep and Mycobacterium and Crohn's disease. Do you think there's anything in that for PSC?
So what the question is referring to is there's something called Mycobacteria paratuberculosis, which is an infection that happens often in cattle. As much as 5 to 10% of the cattle population may be affected, and some people believe that that's the ultimate cause. When this was first described, or when some people described it early 1900s, people proposed that could be the causative bacteria. It's a controversial thing. Some people are trying to develop a vaccine in England against that. It really is associated with Crohn's, and particularly ileal Crohn's. So those who may have Crohn's and PSC, it tends to be more colonic. It tends to be less ileal. So there doesn't seem to be an overlap there where it's a significant proportion. It may be a cofactor for Crohn's disease. When we do these detailed microbiome studies, we don't really see it. So I think that it's a very interesting issue for Crohn's that I think may not be relevant, but it's not, I don't think it fits in with what we know about PSC.
So this is a question, maybe we could, actually Fred might want to start off by answering this. The question, I won't go into the details of the trial, but someone's being asked to take part in a clinical trial, and they're worried about the side effects. Okay, you talked about you took part in two clinical trials. You know that the consent forms are very long. I'm wondering if you could give some patient-centered advice. The trial says it might make you feel more fatigued, it might make you feel more nauseated, dizzy. These are, real-world symptoms that you have to get through the day. Do you have any advice about how you might, from a patient perspective, think about how you tackle these decision-makings at the time of being asked?
Yeah, so I think Matt actually addressed this really well earlier today. In fact, and I think it was discussed that the fact that you're seeing medical providers more often is really going to benefit you in the long run. It kind of goes into the question of how you're going to decide to participate in a clinical trial. And one of the reasons that you might decide not to is because you feel like you're stable, right? And that you really do have something to risk. But if you're not stable, and a lot of us, unfortunately, in here aren't, and they're looking for hope and looking for a solution and an answer. I think that we go in knowing that there may be side effects and that, it's time to try something different.
Yeah. My advice would be talk to the investigator and talk to the coordinator and just listen and get a sense from the investigator whether this is a drug that they've already been using and B, exactly how it's benefiting you and benefiting the community. And also, what are the mitigation approaches that you can use during the trial for those side effects? So, IBAT inhibitors are amazing drugs to treat itch, but they will give some diarrhea. That is how they work. They move the bile acids from feeding back to the liver cells and moving them back into your colon. And when you deliver bile acids to your colon, it will initially cause some diarrhea. So we have strategies in advance that we can discuss. So, don't be shy in asking. The one caveat I will have about who to ask is I think it's great to ask your primary care provider about clinical research, but I would often also maybe not always only listen to your primary care provider. Many primary care providers don't understand PSC as much as you do and as much as your team may, and may always just give you the answer, why don't you wait? Why don't you wait until you know the drug works? I can guarantee if we all wait until we know that the drug works, there won't be any drugs that work because there's no way that you can skip the bit in the middle. Those bits in the middle are not voluntary. So I do get a little bit frustrated when I hear my primary care colleagues telling my patients it'd be better off to wait until you're in the post-marketing surveillance part because then they're not really understanding how to progress. I'll let you maybe start this, Punita, and then we can sort of see if other people want to comment and I can comment. It's really around transplantation, and I'd like maybe to discuss two themes. One is, as you said, Edmonton's an amazing transplant program. What do you think about live donor chains? So in kidney transplantation, the communities got together and you can be in a chain. You can't give, but someone else can, and in kidney transplantation it's much more complicated to match around HLA. What are your thoughts around doing that for liver transplantation?
Wow, yeah. Of course, we need to raise awareness. That story the first day was so inspirational, right? I was talking to my husband actually about being at the conference. He says, I can be a donor. I'm like, yes, you could be a donor too. So, I think people just don't know. And I do think as we raise awareness, this idea that obviously the liver is an amazing organ that can grow back, again, people don't know that. So yes, absolutely.
Yeah, and I think one of the things I tell my patients, and you're right, you see, a challenge for all liver disease is stigma. None of you feel stigma or should feel stigma, but we know from the surveys that we do, we know from how people choose the philanthropic causes they support, that there is still stigma in liver disease. There still is a concept that all liver disease is due to alcohol or lifestyle or viruses, and we also know that's clearly factually not true. And so I tell my patients, because obviously the first question when you see a PSC patient is, what do I do to get on the transplant list? And usually the answer is, I say, well, why don't you just wait 25 years and then when you need one, I'll help you. So, but the more nuanced answer is, why don't you raise the concept that you've got chronic liver disease amongst your friends, amongst your peers, amongst your family? Why doesn't it become a little bit of a topic of conversation over dinner so that people are aware of transplantation, they're aware of it, how amazing it truly is, but at the same time, how to get a liver. It's different in different parts of the world. The US is actually doing very well with organ reperfusion devices. Canada's not yet. Other parts of the world only have live donor transplant. So that conversation to what Dr. Tandon just said is actually very important in then raising awareness and removing the stigma, which we know to be wrong and unnecessary. And then that comes really to one of the final questions, just looking at the clock, around recurrent PSC. I can tackle this, and Dr. Tandon can sort of chip in. When I send a patient for transplant assessment, and that's not an infrequent event in my practice, often the patient will ask me, well, what about recurrent disease? Okay, I'm not going to be cured. Okay, and usually what I do is tell them this is not the time to worry about recurrent disease. We'll focus on today, your quality of life, and prolonging everything with a new liver. But recurrent disease is a reality, and it is a frustration for patients that it feels like there's not enough research on recurrent PSC. There is research on recurrent PSC, but it's a subset of hepatology, it's a subset of transplant, it's a subset of PSC. And you heard earlier I think it was yesterday, it's even more complicated because you've got your old disease, plus you've got your new disease, which is all the new medicines and the operation and all the surgery. And so I think to reassure people we are interested in recurrent PSC, we do see it as important. We recognize that doing trials in recurrent PSC is very hard and maybe nearly impossible because of the number of patients that are spread out. But we would apply therapies to patients with recurrent PSC. I work in Canada. We do use bezafibrate. We do use vancomycin for our patients after liver transplantation. It's empiric. I do it in collaboration with my patient. I tell them I don't know. Okay, I don't have the answer. Okay, but if there's evidence from repurposing those drugs in other settings, then I'm willing to, if you are, to take on board and to try. So we haven't forgotten about recurrent PSC. We would apply new science to recurrent PSC as quickly as we could, but it's a subset of already a very, very difficult problem. I don't know if our speakers want to end by having any other comments. I think we've managed to use up all of your energy over the last couple of days because the questions, either you've run out of questions or we have answered all your questions. So with that, I'd like to thank the panel for their speaks. And that brings to end the sort of formal parts of the sort of lectures from over the last couple of days. I know there's more to go on, and Audra's going to come up and give you the last few instructions about tonight and tomorrow. Thank you.